Hi, this is Dr. Frank Chopatini with the Church of Rational Truth. Today we're going to do a slightly different lecture. We usually do lectures on morality or some interesting topic like that, but we're going to change it up. We're going to talk about something that is in the news recently, a new drug that's been pretty groundbreaking or had a very sensationalist result in one of its trials, and that is the medication Dostarlimab. It was recently highlighted because of a clinical trial that had a 100% success rate in cancer remission for, I believe it was just a certain type of rectal cancer. We're going to talk a little bit about that, mostly because the church is obviously very interested in things that promote longevity and health, because those are big things that we wish to promote, and I think it's important for us to be kind of educated on this new medication or this new possibility in terms of cancer treatment. So first off, the big headline is that it had a 100% recurrence rate. Does that mean that we have gotten this magical medication that cures cancer? Probably not. I hate to break it to you, but this is probably not going to be the one medicine that can cure all cancer. But the good news is, it is a very exciting medication, or at least from this one result. For people who do not have a lot of experience with clinical trials, who do not have a lot of experience with the scientific method in general, this was one small trial with, I think it was about 18-ish patients that were involved. This happens at the end stages of testing medications where they finally approve it to start actually using in practice. They're looking for side effects, they're looking for how successful it is, they're looking to see, can this be something that we can continue to study. So it is not an end-all be-all study, it is not an okay, now approve it for use. They have been trying to push this medication as quickly as possible through these last few trials, but what they'll probably end up doing is now doing new trials with larger amounts of patients to see, does this still have the same response? Can we still see that this continues to work in fighting cancer? The medication, I read up on it a little bit because I am not an oncologist, I'm a family general practitioner. I do not see a lot of primary treatment of cancer. Usually if I have someone with cancer, I'm referring them to an oncologist. So this is not my area of expertise, but in my little bit of research, this medicine was already being used for certain types of endometrial cancer that had this similar percentage of a DNA mismatch repair that was going on. So basically, the way cancer works is cells in our body usually build up genetic defects that allow them to build up even more genetic defects and continue to multiply unchecked by the body. As these defects or mutations build up in this cell line, they become more evasive to the immune system, they multiply faster, and that is basically how cancer exists. And these certain types have a cell protein on them that works very specifically to help prevent these cancers from being seen by the immune system. Normally, our immune system is made to get rid of foreign things, things that our body doesn't produce. If we are attacked by a germ, a parasite, a virus, our body is meant to use our immune system to determine what is ourself and what is not ourself. And if it's not ourself, we usually make antibodies against that thing. The antibodies attack it, and our body knows to remove it. If it's part of ourself, we don't want to attack it, because if we attack parts of ourselves, we destroy ourselves, and that's how we get autoimmune diseases. We make these antibodies against ourselves. And so what these cancers do, normally our body wants to get rid of cancer, but has the problem that cancer is ourselves. So we have to look for certain proteins on that cancer to determine that that is different than ourselves. So if it makes mutated proteins, our body can see it and say, these aren't our normal proteins, let's destroy these cells, they aren't us. But what some types of cancer do, and this is what this medication is for, some types of cancer make a protein on the outside of them that tells the immune system, whoa, 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 I'm you, don't attack me. And that's what a lot of our cells do. Our cells usually have normal proteins that we recognize as ourselves, so our immune system knows not to attack it. And so these cancers that normally would be attacked as something that is bad for us kind of make this veil, or they make this kind of protection fake ID, basically saying that, no, I'm a normal cell, don't worry about me, immune system, you shouldn't fight me or attack me. And so certain types of cancer who use this as a mechanism to survive and not get removed by the immune system, they can then continue to propagate unchecked. Our body does not stop those cancers from growing. So for these specific types, what this drug does is it is whenever you see a drug that ends in MAB, M-A-B, that usually is a shorthand for monoclonal antibody. Just like the antibodies in our body, each antibody is specific to one thing, and when we make a whole lot of one specific type of an antibody for one thing, it is a monoclonal antibody versus one that can have lots of different things that it attacks, usually polyclonal or multiple different types of antibodies. So this is a drug that is basically immunoglobulin G, which is the most common immunoglobulin or subtype of antibodies in our bloodstream. Sorry, this is probably getting way too advanced. But it is one type that specifically targets this protein that those cancers show. And it's not just cancers, it's regular cells in our body, but the one that these cancers have used this trick to get around, this antibody actually goes and hits those proteins. Now, normally, a antibody hitting our own cells would or could cause an autoimmune disease because these antibodies are targeting our immune system to attack something. But in this case, we're targeting the immune system to attack something that we don't want, these certain specific types of cancers that are showing this protein that usually evades our immune system. So what happens? Now, instead of being a way to evade the immune system, we have now used this drug to get the immune system to now specifically target these cells. So you've kind of turned its trick against itself. You turned the trick that this cancer is using to stay alive to now turn it into the thing that is setting off the immune system. And this has a benefit versus regular chemotherapies because chemotherapies are not very specific, or they're less specific. They just kind of destroy, and this is a big generality, but they destroy replicating cells in general. And a lot of our cells replicate, and that's not very discriminate. You want to only kill the cancer, you don't want to kill other things. Versus this treatment, the benefit is not all the cells are using this protein to evade the immune system, and it's in the highest concentration in some of these cancers. So this is a much more targeted, specific treatment, and therefore it will hopefully have fewer side effects, be better tolerated, and destroy fewer healthy cells, and only be destroying these cancer cells. Now, why this isn't going to treat all cancers? It's because not all cancers use this type of way of evading the immune system. In fact, not all of them probably even evade the immune system, at least this specific way. So that means it's going to be specific to some types of cancer. The good news, though, is this is still a very new field. These medications have only been around for 5-ish years, so it's very advanced. It's still very open in terms of how many different types of cancer this can treat, and it seems like this is some very good preliminary information. The big question is it going to hold up the test of scrutiny? For us being rationalists, we have to be very wise about what we adopt. We have to be very wise about accepting something because it will lead you to false conclusions if you jump in and just go gung-ho and accept something as true when you don't have an appropriate amount of testing and doubt. This is what sets us religiously apart from many other religions, is that we will not just go whole hog into something when we just get a little bit of data that proves our point. We need a lot of data. We need to constantly be checking and proving and making sure, because if we just went on this set that only dealt with 18 patients and let's say we just got really lucky statistically and it looked a lot better than it was, well, we might be giving a treatment that doesn't do anything for years and years and years and years, and that ends up causing a lot more harm. So the same thing with this. This is going to have to go through more testing. This is going to have to be confirmed by other clinical trials. We're going to have to see long-term what happens with this, and there's going to be a lot of analysis and evaluation of this new medication. Hopefully it does work. Hopefully it does advance the types of the types of cancers that we can treat. But this is very, very early. We have to hope that it continues being promising, but we have to be reserved, and you have to get the proof to really show that this is going to end up doing what we think it's going to be doing. So I would say this is kind of a little bit of hope or a little bit of a brightness at the end of the tunnel, but it's absolutely not something that is going to be the end-all be-all for cancer. I would say I'm very hopeful that it will be a very successful treatment for many types of cancers. That would be amazing. But I don't have huge hopes that it will be all of a sudden now we've cured completely all cancer. I would hope many types of cancer. Hopefully, it opens up even more doors in terms of cancer treatments that are less toxic or easier to tolerate. But time is going to tell. We're gonna have to study. We're gonna do more analysis. We're gonna have to continue to be rational to find the truth, and that's really what we want. And I really applaud them for that. This is a great scientific advancement, and let's just hope that the more data we get continues to go down this same pathway. If so, that would be a miracle, a blessing, and very good news. And I would like to thank the scientists, hopefully not too presumptively, on all their hard work, because they've probably been working for years on this, and a lot of times you end up working for years and still not getting something that makes a difference. Let's hope that this continues to make a difference, and that these scientists end up saving many, many lives and improving the quality of life for many people who have to suffer from cancer. Old business. Since we're kind of done with that topic, the two things we're going to vote on are, once again, putting the money back into the general endowment, reinvesting it from last week, or we're going to put the money again into the new church and library fund. So we will take voting on that this week. It'll end on Saturday, and during next week's video, we'll talk about where that money is going towards. And I think, what was it, $130-ish from the passive income? So we'll do that, and then we'll get back to you next week. Thank you all for watching. You all have a great rest of your Sunday, and bye-bye.